Thank you for joining us today. Our speaker is Dr. Catherine Albright. She's an assistant professor in the Department of Obstetrics and Gynecology here at the University of Washington. Dr. Albright trained on the East Coast and came to join our faculty in 2016 following the end of her MFM and research training at Brown. Her research interests center on the impact of maternal medical complications on pregnancy outcomes. Her early work was in the rapid identification of maternal sepsis, and then more recently she's investigated how maternal comorbidities like hypertension impact pregnancy. She's currently involved in a project evaluating cardiac exercise physiology with Dr. Buber, and she's mentoring me on a study on pregnancy and adult congenital heart disease. Dr. Albright has been instrumental in starting our combined cardiology maternal fetal medicine outpatient clinic, where we see women with cardiac conditions that are both congenital and acquired. She will therefore accordingly speak to us today about the reproductive impacts of congenital heart disease. Thanks, and please give her your attention.
Great. Thanks, Jill. I have no disclosure. So our primary learning objectives today are to first understand pregnancy physiology, and I'll spend a decent amount of time on that, and its impact on ACHD. To recognize the importance of preconception counseling in these women, and also to briefly discuss some maternal and fetal complications in the setting of ACHD, including a couple of contraindications. The real learning objective, however, is to take, when you see this as a cardiologist, take you from that to this. So I'm going to start with just two cases that I saw over the past couple of years in combination with you guys. So this first one is a repaired TET, which is a 31-year-old G1 with a history of repaired tetralogy of Fallot. No past medical history, past surgical history was significant for her tetralogy repair, as well as a pulmonary valve replacement with a Mays procedure for AFib and a left pulmonary arterioplasty. She was taking no medications except for prenatal vitamin when I saw her, had no allergies. On review of systems, she reported some shortness of breath with some kind of mild exercise. She attributed this to being out of shape, and otherwise her cardiac review of systems was negative. Her pre-pregnancy cardiac testing overall was unremarkable, with a CPET showing a moderate cardiac limitation to exercise and a TTE that was overall normal in the setting of a repaired tetralogy. Her antenatal course overall was pretty stable, with echocardiograms that we did every trimester that remained stable throughout her pregnancy, and we planned for a delivery at term. She presented to labor and delivery at 38 weeks and 6 days, reporting that her baby was moving less. She was diagnosed with oligohydramnios, or low fluid, and was recommended to be induced. We attempted to induce her, however, failed in doing so. She arrested at 4 centimeters dilated after a couple of days. We did a C-section. She had a postpartum hemorrhage, but overall did pretty well in the postpartum course. She got Lasix for 2 days in the setting of presumed volume overload, given her prolonged induction, and was discharged home in stable condition on post-op day 3. She unfortunately came back at post-op day 5 with pulmonary edema, received aggressive diuresis, and was discharged home on post-op day 7 for additional week of diuretics. On follow-up, when I saw her about a week later, she had lost about 20 pounds, which meant that she, from our standpoint, pretty volume up, and was feeling much improved. And on 6-week follow-up, her course was uncomplicated. She's had a repeat echo and repeat visit with you guys, and is doing well. Case 2, many of you know this one, is a woman with tricuspid atresia, status post at AP Fontan. She's a 35-year-old G1 when I saw her, history of tricuspid atresia with her Fontan. Her past medical history mostly was related to her Fontan procedure with SVT and hepatic fibrosis. However, she was also hypothyroid. Her past surgical history was significant only for her Fontan procedure, as well as an ablation for SVT. She was on the following medications when I saw her initially: prenatal vitamin, Synthroid, and Nadolol. She had been on spironolactone prior to her pregnancy, which we switched to eplerenone, and she had been on Coumadin, which we switched to Lovenox. She overall didn't feel limited at all, and had a pretty negative cardiac review of systems. Her pre-pregnancy cardiac testing was accordingly really pretty normal in the setting of a Fontan. She had normal PFTs, a cath that showed a really well-functioning Fontan, and an echo that was consistent with her procedure, but with a well-functioning systemic ventricle. Her antenatal course was complicated in a different way. So she had stable echocardiograms and stable Lovenox dosing. We monitored her 10A level frequently throughout the pregnancy, and she remained with a mid-interval level of between 0.6 and 0.9, which is where we wanted her. She unfortunately had some obstetric complications and had a growth-restricted fetus with a large preplacental hematoma. It's not normal for us. Her fetus was quite small with an abdominal circumference of less than the first percentile, which signifies pretty significant growth restriction. And umbilical artery Dopplers that were very elevated, meaning that her placenta was just not perfusing her baby. She unfortunately also had new onset SVT at about 30 weeks, requiring brief hospitalization and was transitioned from Nadolol to diltiazem, and was eventually, in the setting of all of these complications, admitted to our service at 32 weeks for delivery planning. She was transitioned to a heparin drip, had pretty routine fetal monitoring, and then we planned a cesarean delivery in her, given her both cardiology and obstetric complications. We did monitor BNPs throughout her pregnancy, and as you can see, this is kind of all the way throughout her pregnancy. Her baseline BNP is in the 150 to 200 range. She remained pretty stable throughout the pregnancy. That spike up to the 300s was when she came in SVT, so we were entirely sure. She underwent a cesarean delivery about a week after we admitted her in a setting of fetal distress. Upon entry to the uterus, she had about 1,500 mLs of frank blood come out, which was kind of with this preplacental hematoma, which is not normal. Her overall QBL, we had switched from EBL to QBL at this point. Quantitative blood loss was about 2,577 cc's. She had a birth weight, her baby had a birth weight of 3 pounds 4 ounces, which was small for gestational age in the 6th percentile. She had a planned CCU admission post-op given her complications, but did well, was transferred to the OB service on post-op day 2 and eventually discharged home on post-op day 4. For her follow-up, she had a stable echo at 2 months postpartum and reported doing well. And of note, her infant was discharged on day of life 30. So I'm going to talk, I'll come back to those 2 cases as we kind of go through the rest of the talk. So a little bit of OB background. I can't give a cardiovascular disease talk without talking about maternal mortality in the United States. This, I think, is one of the most telling graphs about maternal mortality in the United States, saying that, around 1990, looking at all of these other developed countries, we were kind of at the high end, but still in the mix. In 2000, we started to go up, whereas everyone else started to go down, and in the 15 years following that, the US maternal mortality rate skyrocketed, whereas every other country seems to be doing well. Thinking about causes of pregnancy-related death in the US, cardiovascular disease, you can see, is the top right here, followed by a couple of others, and then cardiomyopathy is still up there. About 1 to 4% of pregnancies in the US involve cardiovascular disease. And then getting to the meat of what I'm talking about today, thinking about adult congenital heart disease, there has been a significant increase in women who are pregnant with congenital heart disease, increasing from 6.4 to 9 per 10,000 delivery hospitalizations in the decade between 2000 and 2020. Women with ACHD account for about 2% of hospital deaths compared to the kind of 0.09% of admissions, and 1 to 4% of cardiac complications, depending on how that's defined. You guys know the cardiology history, but I think it's interesting, so I'm going to present it really quickly. So CHD affects about 1% of live births, but accounts for about 30% of all anomalies that babies are born with. Before the development of corrective surgery, many died before, in childhood, before reaching adulthood, or right after birth. In 1938, Dr. Robert Gross performed the first successful PDA ligation on 7-year-old Lorraine Sweeney. And then in the 50s and 60s, the advent of bypass and surgery under hypothermia really increased the types and complexity of surgeries that we were able to do. I like this demonstration because, as you can see, in the 1960s, the pink is babies who died in the first year of life after congenital heart disease and congenital heart disease surgeries. About 50% died in the first year of life in the 1960s. Compared to 2010, 10% die, but 85% survive into adulthood. What does that mean? Of those, half of those are women. So those women are surviving into adulthood and interested in having children of their own because they're doing well. Of note, in 1950, at the age of 19, Lorraine Sweeney returned to Dr. Gross during her first pregnancy because her OB was terrified. She ended up having a successful pregnancy and then kind of goes down in the history books as being the first woman to have a pregnancy following congenital. So thinking about what we see in pregnancy for congenital heart disease, this is, of course, of women with congenital heart disease, these are the percentages that we see. So most commonly we see things like VSDs and ASDs, but of note, and we, thinking about my population, about 12% are actually women. Okay, that's basic background. Part of the meat of my talk today is really going through some pregnancy physiology and trying to relate it to how this might impact a heart and a cardiac repair. So this is just kind of a little bit in the weeds of pregnancy physiology. So during pregnancy, there's a really significant increase and change in many, many, many hemodynamic parameters. There's kind of going through first, second, and third trimester, heart rate increases pretty consistently throughout pregnancy, going up about 15 to 20% by the third trimester. There's additionally about a 50% increase in plasma volume that happens mostly in the second trimester. There's a decrease in systemic vascular resistance by, honestly, about 35 to 40%. This happens mostly in the first and second trimesters, which accounts for this 5% decrease mostly in diastolic blood pressure. All of this leads to a pretty marked increase in cardiac output by the second and third trimester, up 35 to 45%. If these things can't happen or the heart cannot compensate for these things, you start to see cardiac complications. This is just kind of a nice graphical representation of the things that I've talked about. I think it's easy, kind of nice to see it in two different ways. Here's the kind of almost linear increase in heart rate. This is weeks of pregnancy on the x-axis. SVR decreases really significantly right at the beginning of pregnancy and then kind of remains stable and increases toward term. Blood pressure diastolics, the solid line here, you see this slight decrease in diastolic blood pressure, which goes back up to normal at term. And then cardiac output, you have this pretty marked increase up into the line. Thinking about, so adding on stages of labor. And so stage 1 of labor is when women are dilating, stage 2 of labor is when they're pushing, and then postpartum, as you know, is right after the baby is born. Looking at cardiac output and stages of labor. So this is kind of an even higher increase. So during stage 1 and stage 2 of labor, the cardiac output increases up to about another 50%. And then right as the baby delivers, there's an increase of about 60 to 80% in cardiac output that then pretty rapidly decreases in the first hour. I'll come back to this in a second, but this was, I think, just a kind of interesting, cool study that was done in the 80s that I don't know would be done now. But they recruited women who were laboring and did echoes on them as they were laboring and pushing. And this is kind of the basal tone, so when they're not contracting, C is when they're contracting, and this is cardiac output. This is women below 3 centimeters, so really early labor, and you can see with each contraction, your cardiac output is slowly, up. This is kind of active labor. You see a pretty marked difference in the slope between these two, so a really marked increase in cardiac output. This is the very end of labor, once they're beyond 8 centimeters, and you can see that between non-contracting and contracting, there's this really huge dynamic change in the cardiac output during labor. And so that, adds to this 50 and then 60 to 80% increase. Thinking about heart rate and blood pressure and plasma volume, heart rate decreases or increases with contractions. Usually this is mostly a pain response, and then decreases kind of continuously after delivery. Blood pressure starts to decrease within 48 hours, but then we do see this remobilization of fluid at about 3 to 6 days postpartum, and that can increase women's blood pressure as well. So a lot of these women with cardiac concerns, we do need to be watching past the kind of normal postpartum period, because we see a remobilization of fluid where they might not be able to compensate it in that 3 to 6 days postpartum. The plasma volume goes with the cardiac output, but there's a pretty immediate autotransfusion right after the placenta is delivered. You get about a 500 cc bolus of blood into the circulation immediately after placental delivery, which in women with any sort of heart issue, heart disease, abnormal diastolic function, abnormal systolic function, they may not be able to compensate for that. So we do worry about pulmonary edema, especially in the setting of the immediate postpartum period. And then this is just to say that by about 3 to 6 months postpartum, everything hopefully in a normal person should return back to normal. There are also structural cardiac changes. I'm not going to go through these in a huge amount of detail, but LV and diastolic volume increases during pregnancy. And this is all normal pregnancy. None of this is in the setting of congenital heart disease. The LV and RV mass increases by approximately 50 and 40%. Ejection fraction has differing reports throughout the literature as to whether it increases or whether it stays the same in normal pregnancy or actually decreases a little bit. And then two recent echo studies actually demonstrated that about 20% of normal healthy pregnant women have evidence of diastolic dysfunction on echo around term. We don't do anything about it, but it's interesting. These structural changes in a normal woman should return to baseline by about a year postpartum. We see from those structural changes, we see kind of a similar EKG changes in pregnancy. So the EKG in a normal pregnant woman is going to look slightly different than someone who is non-pregnant. If you have an increased heart rate, you can see Q waves in lead 3, this small reduction in the PR interval, and kind of most significantly a leftward shift in the Q. I'm not going to go too much into other changes in pregnancy, but just to kind of flush out some of the normal physiology. Respiratory-wise, the big thing is that the minute ventilation increases by about 20 to 40% because of an increase in tidal volume. Women aren't breathing faster, they're just breathing deeper. And what that does is that decreases the PaCO2 to be about 30 millimeters of mercury in the setting of pregnancy. So the kind of normal 40 that you would see outside of pregnancy. So if you have someone who's on a vent, who's pregnant in the ICU, 40 is bad, 30 is better. Really, this is a compensated respiratory alkalosis because of the decrease in bicarb and decrease in PaCO2. And what this does is it can unfortunately lead to, in women who get sick, a really rapid decline in oxygenation and a decreased ability to compensate for any sort of metabolic acidosis. Hematologically, women are much more prone to pulmonary edema. And this is basically because you have a pretty significant dilution of the blood. So the red blood cell mass goes up by about 10 to 20%, but this is far outpaced by the increase in plasma volume, which leads to a dilutional anemia. This similarly leads to a decrease in albumin and colloid oncotic pressure. So women are much more likely to develop pulmonary edema because of this decrease in colloid oncotic pressure, especially when you add in all of the hemodynamic changes that we see throughout. Less of a big deal. Everyone knows that pregnant women are at high risk of clot. The reason for that is because of this pretty marked increase in most of the clotting factors. And so in women with heart disease who are worried about blood clots outside of pregnancy, really important to pay attention to that. I'd be remiss not to talk about BNP in the setting of a cardiac talk in pregnancy. This was a pretty nice study that looked at non-pregnant controls compared to healthy women per trimester and postpartum. And they noted that yes, BNP is increased during normal pregnancy, pretty stably throughout with a little bit of an increase in the 3rd trimester, but notably all really within what we would still consider normal. We're not seeing abnormal elevations in BNP. These two studies were looking at women with congenital heart disease and looking at BNP. This study on the left shows just the distribution of BNP levels. This was done at 20 weeks, just times 1. Most of them you see are kind of in the 0 to 200 range, with a couple with much higher BNPs. But thinking about which women had cardiac events in pregnancy, no one with a BNP below 100 with congenital heart disease had a cardiac event in pregnancy, at least. A similar study looked at average BNP levels in cardiac disease patients and in controls. And not surprisingly, the women with cardiac disease had higher BNPs, still usually below 100, but they found that a level of 100 was predictive of cardiac events. So if you had a level below 100, that had a very high negative predictive value for cardiac events during pregnancy. I'm not going to go through this slide in a lot of detail, but only to say it's the pharmacokinetics of drug metabolism are changed vastly throughout pregnancy because of all of these things. Decreased or delayed gastric emptying, increased cardiac output, increase in total body water, increase in fat, increase in renal blood flow, decrease in albumin, and a change in the hepatic enzyme metabolism. These are, a handful of the hepatic enzymes. Most of them actually have an increase in activity. There are a couple of them that have a decrease, but I'm going to point out in particular from the cardiology perspective, CYP2D6, which mostly metabolizes metoprolol. Metoprolol is mostly metabolized by CYP2D6 as well as propranolol. This was a nice study done at UW, or partially at UW, where we took, this is just a representative example of one pregnant woman. The squares are what you want to be looking at. So this is the concentration of metoprolol in a woman's body after a dose. This is 3rd trimester of pregnancy. Up here is postpartum. So you can see that the same dose of metoprolol in pregnancy, you had about a quarter of the concentration in their blood, which basically means that you're just not, you think you're giving them enough, but you may not be. So it's important to think about increasing not only the dose, but potentially also the frequency of dosing. This is just a nice representative example. I could take almost any other drug and you'd see some somewhat similar effects. Okay. The meat of my talk today, however, I really wanted to talk about kind of reproductive planning and preconception counseling and how to talk about pregnancy to these women and what really are the risks. And what I want to stress is that every time any of you see a woman who is of reproductive age, that is an opportunity for reproductive planning and preconception counseling. And what I mean by that is that it's worth asking this one question. Are you interested in pregnancy now or in the future? If they say no, never, the next question is, what are you doing for contraception? What are you doing to prevent your pregnancy? And we'll talk about why that's important. If they are maybe interested now or maybe later, you got to talk about all the things that we're going to talk about going forward, but then also, what are you doing for contraception? We don't expect, all of the cardiologists to really go into the, the meat of the contraception, but that should be a, hey, you should talk to your family practice provider or your OB about what you're doing to prevent pregnancy. And of course, if they want to be pregnant now or soon, that's a different discussion and what we're mostly going to talk about. When I was bringing up this talk to my colleagues, one of them said that you have to make sure you tell them this. So one thing that you shouldn't ever tell a woman is you can't get pregnant. Because what you mean is I recommend that you do not get pregnant because you are too high risk. What she hears is you are infertile. And so then she comes to us and says, well, my cardiologist said that I couldn't get pregnant. Not what they meant. So word of caution. Really important because still in the United States, about 50% of pregnancies are unintended. It's about 45% now. We're doing a little bit better. This is a nice study from the New England Journal that just looks at risk factors for unintended pregnancies. Age 18 to 24, low income, not completed high school, non-Hispanic, Black, and apparently cohabiting but never having been married. So it's unintended. I'm just going to read the top of this slide because it says it all. In 2008, the 2/3 of U.S. women at risk of pregnancy who used contraceptives consistently accounted for only 5% of unintended pregnancies, meaning modern contraception works. As an OB at a GYN, this is my obligatory contraception slide. I have to talk about it. These are the methods that if people don't want to get pregnant, that we highly recommend. IUDs and implants. These are the methods that are okay. Depo, pills, patch rings. These are the methods that's just, if you don't want to get pregnant, you probably. And it's important to kind of think about, and when we talk about this, it's important to think about perfect use versus typical use. And all of the CDC studies are looking at, so if someone uses this method perfectly all the time, how does it work? Versus how do people normally use this method? With obviously an implant, it's the same. Perfect use, typical use. You implant it in your arm. It doesn't go anywhere. You don't have to think about it. It's the same. The one that I always like to bring up, and my husband was shocked by this and was kind of dismayed knowing that he had, you know, potentially been at risk for unintended pregnancies for many years. Pills, perfect use, same time, every day, never miss a pill, 99.7% effective. Typical use, a 7% per year pregnancy rate. Most women are, that's too high if you don't want to get pregnant. And you could go through the rest of this, but thinking in particular about contraception, there are 2 studies that I saw that looked at women with congenital heart disease and they kind of asked about contraception in general. In one study in 2015, in an ACHD clinic, about 25% reported using no contraception at all. This is not stratified by people trying to get pregnant and not trying to get pregnant. And 16% reported using a less effective method. So we consider that failure rates of, you know, these are those kind of bottom condoms withdrawal. In that study, in another one, they kind of extrapolated and thought that somewhere between 25 and 45% of pregnancies in women with ACHD were unintended. And so if you think about unintended pregnancy rates, if you have a normal, healthy woman who has an unintended pregnancy, that's not ideal, but maybe not the end of the world. If you have someone who is quite sick, who we think has really significant maternal and fetal risks, it's a different thing. So from our perspective, and maybe I need to talk to the children's cardiologists and not you guys, but the discussion really should happen as soon as a woman could theoretically get pregnant, so at menarche. It's important when we're thinking about these to consider kind of the risk of blood pressure, the risk of thrombosis when you're giving someone an estrogen-containing birth control. That said, to take a step back, I think it's always important to think about the fact that the risk of a combined oral contraceptive is never going to be as high as the risk of pregnancy. So if that is your comparison, if you're comparing giving them a combined oral contraceptive versus them being pregnant, the pregnancy is much higher risk. IUDs are almost always safe. If you have someone who has really significant disease, Fontan physiology, eyes and fingers, maybe you put it in when they're actually at a clinic. But otherwise it's safe. Emergency contraception is safe and sterilization is also safe, but of course, if you have to do a procedure, you have to kind of think about it. So assuming we have someone who wants to get pregnant, what is our pre-pregnancy evaluation? What is kind of recommended? And so the AHA actually has a nice statement that has come out about, you know, what should these women have within about the year prior to them getting pregnant? And this includes a history and physical, including a history of cardiac events, a medication review, which really is mostly talking about, hey, are you on any teratogenic meds that we need to consider switching or at least have a plan to transition you off of? And then a review of systems, including cardiac. Studies include all of these, CBC, lights, thyroid LFTs, some sort of EKG, an echo, maybe a CPET, maybe a cath if they're in kind of the group of women that you think that they need that, and I leave that up to you guys. The other thing that's important to point out is that maybe they need a genetics referral. We're actually seeing a lot of women who, when we're testing them with tetralogies, do have some sort of abnormal genetic profile, most commonly 22q11. And then that heritability is very different, and that discussion is very different when we're talking to them about kind of the risks to their pregnancy and the risks to their fetus. So are we good at doing this evaluation? I'd like to take a look at our stuff here. I haven't had a chance to do that. I'll do that at some point. But this was a claims database study that looked at 2,000 women with CHD and just looked at when they got pregnant and looked at the year beforehand and did they have all of those tests. This is not, we don't know if they got preconception counseling, we don't know who they were seeing, we don't know how many docs they saw, we don't know any of that. This is just claims data. But less than 1% had all of those tests within the year prior to the And this is just the kind of graphical representation of what they had versus what they didn't have. And of note, again, we don't know who was trying to get pregnant, what the discussion was, but about 10% of women are on a teratogenic drug and within the year prior to them getting pregnant. Again, we don't know if this was talked about and planned and there was a planned transition or if not, but it's important to know that a good percentage of these women are on something like an ACE inhibitor or on warfarin, and needs to be at least have a plan in place for what to do if they get So what about preconception counseling? So you've done your evaluation. How do you talk to these women? So unfortunately, there's limited evidence that preconception counseling does anything as far as kind of pregnancy outcomes. That said, these two studies, one was in a chronic kidney disease clinic, one was in a congenital heart disease clinic. Women did feel that they were very satisfied with the counseling they received, especially when it was in a multidisciplinary fashion, meaning that they at least were happy with the information they received. Whether it changed their minds about what they were going to do, it didn't really matter, but they were happy to have the information. Thinking about CHD in particular, there have been a couple of preconception counseling studies, and Jill will be doing some more. But in general, just to kind of distill it, women in the past really describe a lack of any sort of counseling with regards to pregnancy. They reported that they either received no or inaccurate information. And they were concerned about not only their fertility and risks of pregnancy, but also about what their risk was of transmitting their heart disease to their baby. And again, whether we told them or not, they didn't hear it, so that's what matters. More recent studies have shown some improvement with documented preconception counseling, with about 2/3 of women in specialized congenital heart disease clinics receiving preconception counseling, but that still means 1/3 of them at least don't have documented or to know whether they actually received it. So what are the elements of preconception counseling? And I'm going to go through these kind of briefly and talk, and this is where I'm going to get into the meat of kind of risks to pregnancy. So when I do a preconception counseling visit, this is the framework that I have in my brain about how I talk to these women. And we'll start with kind of the thing that no one likes to talk about is the getting pregnant and the staying pregnant. So infertility in a congenital heart disease population is probably similar to that in the general population. So these women are likely not infertile, is kind of the take home. I'm not going to go into the management of infertility. That is not for me, that is not for you, that is for someone else entirely. But it can be more complex if we're doing stimulations or egg retrievals or IVF in complex heart disease patients. Miscarriage is a little bit of a different thing. It's possibly more common overall. This study was just a systematic review that looked at about 2,000 women in a bunch of different studies to look at rates of miscarriage per congenital heart disease. They put the expected rate of miscarriage of about 10%. I think that's a bit low. The expected rate that we quote women is about 20%. That said, if you take their expected rate and you kind of look across here, most of these less bad congenital heart diseases seem to have miscarriage rates that are pretty similar to what we expect. Where we see a big difference are really in our Fontans or our women with cyanotic heart disease. In one study in particular who looked at Fontan circulation, they found that in general those women are at much higher risk of miscarriage, especially those with baseline cyanotic. So I mean, there aren't not many people who had baseline SATs less than 85, but of those, all of them miscarried. And then of 116 women who were not cyanotic as defined by a baseline saturation greater than 85%, about half of them miscarried, which is pretty significantly higher than what we would expect for a general pregnant woman. Okay, now this is really kind of this is where I'm going to tell you guys where, what are the risks, what are the studies, what are we really talking about? And when we think about pregnancy and preconception counseling, how as an MFM we think about it is what is the impact of the disease on pregnancy? Meaning, does the disease you have change your pregnancy outcome? Are you at higher risk for some bad thing to happen in pregnancy, preeclampsia, preterm delivery, growth restriction because of your disease, congenital heart disease in this case? And then the flip to that is, what is the impact of the pregnancy, of the physiology that I talked about on your disease? Does it change your disease status because you got pregnant? And I'm going to talk about them kind of all at the same time because the studies tend to look at them at the same time, but they are different, and it's important to make sure that women understand that those two are different. So these are the general risks that we talk about. For fetal and obstetric risks, we mostly talk about fetal growth restriction, which is an antepartum diagnosis. Small for gestational age is once they're born, we put the baby on a scale. Preterm delivery, whether that's because I tell you to deliver preterm or you spontaneously deliver preterm. Usually hard to differentiate in a lot of these studies. maybe C-section we always talk about. I'm going to bring this up here and not talk about it again. There's about a 5% risk of congenital heart disease in all comers of women with congenital heart disease. If a woman comes in and walks into your office who has congenital heart disease, maybe has about a 5% risk of having a congenital heart disease as well. Often it's often the same depending on the lesion. It's not always the same. I'm going to leave it at that. But for genetics, it's important obviously to talk about things like 22q and 1.1 or Marfan's or hypertrophic cardiomyopathy, because some of those may have a 50% transmission risk if they're autosomal dominant. The maternal complications that we talk about really are arrhythmias and heart failure, but then it's also important to talk about the risk of prolonged hospitalization, especially in the setting of pregnancy, and then of course death, and then long-term complications I'll talk to you about a little bit later. So this, you're not meant to read this, but this was a nice review in the UK looking at about 1,300 pregnancies, and these are the individual congenital heart diseases. This is birth weight percentile on the y-axis, and so this is normal controls. Fontan is over here. You can see, and so it kind of goes from least complex to most complex. You can see that the birth weight percentile just pretty steadily decreases in women who have congenital heart disease. Preterm delivery, this is gestational age in weeks. This is the same, these are the same congenital heart diseases, a little bit less of a trend, but you can see when we get over to the Fontan, yeah, they probably do deliver preterm. Whether that's because I tell them to deliver preterm or they go into labor preterm, hard to know. So then the risk assessments are kind of getting to what are the actual risks. And I'm only going to talk about 2 risk assessments just because it's the ones we tend to use. I'm going to talk about the Modified World Health Organization. I'm going to talk about CARPREG. There are many others out there that I just don't have time to. So the Modified World Health Organization is nice because it is a lesion-specific classification. It's really easy for the non-cardiologist to look at this and classify my patient, which is one of the reasons I like it. It's 5 categories. Class 1 are the low risk, minimal increased risk of morbidity and mortality, kind of low cardiac event rate. These are the kind of simple lesions. Class 2, small increase of maternal mortality, a little bit higher event rate. These are the repaired TETs, arrhythmias, most unrepaired ASDs or VSDs, Turner syndrome without aortic dilation. Why they didn't just call this class 3, I don't know, but they call it class 2 to 3. This is the intermediate risk, higher event rate. This is getting to the women who you kind of have to start thinking about. Now we're starting to think that these are slightly more complex heart diseases, mild LV impairment, some valvular heart disease, Marfan with some aortic dilation, but not too much aortic dilation, repaired coarcts, etc. Class 3, these are the ones that we actually really worry about, but we don't tell not to get pregnant. Significant increase in risk, event rates of up to 30%. These are the systemic right ventricles with good function, the Fontans that are otherwise well, the severe but asymptomatic aortic stenosis. And then finally, our class 4s. These are the women that we really should be actively discussing termination with or not getting pregnant with until they have it fixed, if that's possible. With the extremely high risk of mortality or morbidity, and up to 100% cardiac event rate, depending on what you look at and the population you look at. And I mean, this shouldn't surprise anyone. These are the really sick women. Moving on to CARPREG, or the Cardiac Disease and Pregnancy Study. There's CARPREG 1 and CARPREG 2. To briefly talk about CARPREG 1, this was done back, or published back in 2001. About 600 pregnancies, 74% had congenital heart disease. About a 13% complication rate in kind of this, in all comers. Most of these were pulmonary edema and arrhythmias. And about a 20% neonatal complication rate, which included both preterm delivery and small for gestational age infants, with about a 27% C-section rate, which is kind of about what we do in the US. So. The predictors of cardiac events in this study were these, and not surprisingly, as you had more predictors, your risk of cardiac events went up pretty significantly in pregnancy. More importantly, and why I didn't spend very much time there, is CARPREG 2, which was published just, I guess, now 2 years ago, because it was 2018 and it's now 2020. Almost 2,000 pregnancies, almost 300 of which were in the original study, so they kind of reused some of the women. 64% had congenital heart disease. And their goal was to really create a prediction that incorporated not only diagnoses, that is what the Modified World Health Organization uses, but also some other cardiac variables, and then some kind of factors related to the care that the women were receiving. They had about a 16% complication rate, arrhythmias and heart failure being the most common. These were the predictors that they found. And so you can see that you have some history-related things, prior cardiac events or arrhythmias. You have some lesion-related things, mechanical valve or ventricular dysfunction. And then you have some kind of systems-related things relate to care. And not surprisingly, as you go up, your risk of some sort of adverse event in pregnancy goes up. So with more than 4 points, the risk is somewhere around 50%. They then stratified these scores by World Health Organization group. And then, not surprisingly, within each group, as your score went up, your risk went up. Why it's lower risk in class 3 than in class 2, I don't really know, but in general, within each group, the risk goes up as recorded. I like this as a kind of flow sheet, which is in the CARPRIC study, just about kind of this is how we should think about these women, starting with history, going to physical exam, thinking about what specific lesion they have, thinking about whether they have any imaging studies and kind of what those show. How do they present to care? And then what I think is nice about this is that they add all of these other variables that are really important, but that they didn't kind of classify as, didn't add them to their model. But things like medications such as anticoagulants, or if they have a CPET result that's really concerning, or if they're really non-compliant with their care. These things can all add to risks during pregnancy. And because I'm doing a study on CPET, I'd be remiss to talk not about CPET. This is a shout out to the ACHD team, and this is a bike, treadmill, and this is a stationary bike test. There are 2 studies that look at CPET in the setting of adult congenital heart disease. This one looked at 89 pregnancies and 83 women who had a CPET within 2 years of pregnancy. A lot of words on this slide, but basically it says that if they have an abnormal heart rate response to exercise, they do worse in pregnancy, both for maternal complications and fetal complications. This is the better study of the 2, so I'm going to kind of focus on that one. The other study was a treadmill test. This was a single center retrospective study looking at 33 women who had CPETs within 6 years. So a little bit harder to know how predictive that CPET was if it was 6 years prior to their pregnancy. And again, not to go into all of these, they basically found that all parameters were associated with adverse outcomes. So take your pick. I think definitely probably a heart rate response if you're unable to mount an appropriate heart rate response, unable to increase your heart rate, mount that cardiac output that we need during pregnancy, you're going to have higher risks. This one, take with a grain of salt. Okay. The next thing I talk about in preconception counseling is really what's the long, so you get pregnant, but what if you didn't get pregnant? How is your heart gonna, how does it change? Do you get worse faster because of the physiologic changes of pregnancy? And there's not a whole lot of data out there about this because these women just haven't been alive and getting pregnant for long enough to really have this data. But there are a couple that I'll talk about. So this was a nice evaluation from the Zahara cohort, which is one of those other risk predictors, that looked at both RV and LV function parameters in women with congenital heart disease in red and healthy in blue, and kind of looked at 20-week, 32-week, and a year postpartum. And it's only up to a year postpartum, so again, take it with a little bit of a grain of salt. But you can see for most of these RV parameters, and this is all comers with congenital heart disease, yes, the people with congenital heart disease are different than the normal controls. That's not kind of the big deal. But the slope of these lines for RV parameters is probably about the same, maybe with a difference in RVED. The one thing that they found that was significantly different was your LVEF at 1 year postpartum. So whereas this group did see a slight decrease in normal controls at the end of pregnancy in EF, but those women bounced back to normal at a year postpartum. Whereas in the congenital heart disease population, you actually kind of saw them be pretty stable in pregnancy in this group, but with a slight decrease rather than an increase, and that was statistically significant. So perhaps there is a difference in EF, but again, this was only 1 year follow-up. There's a little bit more data specifically looking at tetralogy of flow, because as I said, this is a little bit more, this is one of the more common lesions that we see. This first study in 2013 thought that when they kind of looked at, this was MRIs before and then whenever they had it after pregnancy, looking retrospectively. So this wasn't a prospective study that said we're going to do MRIs in a year and then 2 years and then 3 years. This was just whenever they had one. But they thought that pregnancy was associated with an accelerated rate of RBC remodeling. They didn't have a nice figure, so I'm not going to show them. The next two had nice figures. So this one, this study similarly just looked at their RV size and LV size as well, but the RV size, which is what was significant, and they found that pregnancy was associated with an increase in RV size with a mean follow-up of 2.9 years. And you can see that this slope is just a little bit higher in the pregnancy group compared to the control group who didn't get pregnant. Both increased, the pregnancy group just seemed to maybe increase slightly more. However, on the flip side to that, a different study, and all of these are like 13 to 20 women. None of these are big studies. The flip side to that, in 2017, this group in the UK looked at similar things and saw that women who didn't get pregnant compared to women who did get pregnant didn't really have any major difference in deterioration in RV volume or worsening of PR if they had only kind of mild to moderate RV dilation at the beginning. The one woman who's up here, which what they thought was their outlier, was someone who had a slightly more dilated RV at the beginning, and she did seem to get worse. So if you're okay at the beginning, maybe it doesn't matter. If you're not okay at the beginning, maybe it doesn't. The two other populations that I think are kind of important to talk about are the systemic right ventricle population, for whatever reason. There was one study that looked at this, 18 women, 31 pregnancies, so again, not many. But it did show a significant deterioration for both New York Heart Association class and RV function compared to women who didn't get pregnant at about 51 months of follow-up. The single ventricle Fontan, there's, as far as I can tell, there's no data out there. But I liked this quote because this is kind of what I think most of us believe, is that the delicate balance in the Fontan physiology may be disturbed by pregnancy and not. So that's what we found. Going to medication management, I'm going to take about 30 seconds to talk about this. There needs to be a plan for transition of teratogenic drugs. So ACE inhibitors and warfarin are kind of the big two that come to mind when I'm thinking about cardiology patients. Both of these, they can be on at the very beginning of pregnancy, and then we can transition them off at a positive pregnancy test, because usually these are not drugs that we want them on, or that we want to take them off of if it's going to take them a year to get pregnant, which it might. So usually we'll say, yes, we need a plan to transition, but please stay on it until you have a positive pregnancy test. Call us immediately and we'll switch. And then similarly, I always talk to women about the need to dose adjust during pregnancy, because I find that women are a little bit shocked with how much we check levels of Lovenox, for example, and how much we have to dose adjust a medication like metoprolol, and how high of doses they end up being on and how frequently they have to take them, because they think this is way too high for me. But I think it's important at the very beginning of pregnancy or preconception to say that this is normal, and this is this is something that we will do and we will monitor. Finally, just some anticipatory guidance about pregnancy and how we manage pregnancies. This is just from the World Health Organization, based on when they should get their CV care in pregnancy, based on what class they are, where they should deliver. Not shockingly, if you have horse disease, you need to be seen more frequently, and you should deliver at a place that is a higher level. The other thing that is important for us and for you guys is to realize that basically all pregnancy symptoms are also the symptoms that we ask for that are kind of bad cardiac symptoms. Shortness of breath, swelling, trouble sleeping, all of those things, same in pregnancy. So it's a little bit hard to differentiate. So it's really important to serially assess symptoms and to pay particular attention to things like heart rate, weight gain, and O2 sets. This is a nice table from a recent ACOG bulletin. Again, I'm not going to go through it, but these are the symptoms that people might report. So shortness of breath, chest pain, palpitations, it could be fatigue, all can be normal in pregnancy. If they're really mild, you probably don't need to do anything about it. Again, what I tell women is if you have any of these symptoms that you would just totally brush off if you're not pregnant, probably okay, although let us know to brush it off in pregnancy. If it's something that's more severe, we need to know about it. And then similarly, there are kind of standard physical exam findings. Really, you know, we hear a murmur and we hear an S3 in pregnancy normally. They're not in heart. The maternal testing in pregnancy is kind of the same as you would do pre-pregnancy. We just do it serially. And the fetal testing, we kind of talked about genetic testing. We do or recommend doing fetal echocardiograms in all of these women because of that 5% risk that gets done over at Children's. And then we do growth ultrasounds because of that increased risk of growth restriction. Again, I have to talk about CPET because that's what Yoni and I are doing. We don't normally do it in pregnancy, although there are a couple of studies that have shown that it is safe in normal, healthy pregnant women. The data in the ACHD population in pregnancy is very limited. We don't have longitudinal data about what happens to CPET parameters in one woman in pregnancy, which is the study that Yoni and I are doing, so stay tuned. I think that every woman would agree with this, that the ideal labor is short and pain-free. This is especially true in the setting of adult congenital heart disease. So these are women that we say, hey, you probably should get an epidural. If you were really wanting to deliver at home in the bathtub, I don't recommend it. Regional anesthesia is usually okay. We always have them talk to our anesthesiologists. And routinely, they don't need endocarditis prophylaxis, although that ends up being a discussion between both you guys and us and the patient. We prefer a vaginal delivery for the vast majority of patients. The hemodynamic changes are better, the anesthesia changes are less severe. We'll talk about an assisted second stage, so that's with a forceps delivery, so that way it limits their Valsalva and their pushing. That said, usually if a woman can go to the bathroom and Valsalva, she can push for a little bit, probably okay. The phrase that I usually tell women is that I'm going to allow you to push under observation. We will watch you, we will watch your heart rate, we will watch how you do. If you do okay, you can keep pushing. If we see anything that is funny, you don't get to keep pushing, and then we talk about it. C-section we normally reserve for our standard obstetric indications. So any reason we would do C-section for anyone else, we could do in a woman with congenital heart disease. There are a couple that that we'll sometimes talk about just doing a C-section at baseline. The most kind of, the one that we really do this for are women with an unstable aorta, where we're really doing any sort of. We've talked a little bit about postpartum. We want to avoid them hemorrhaging. Sometimes we can't do that. And we want to diurese them carefully, but usually aggressively. Okay, so going back to these last two patients, and then we're done. So this first patient, remember, she is a repaired TET who had a Mays procedure for AFib, who otherwise is feeling generally well. We put her into a modified World Health Organization class 2. I initially put her into a New York Heart Association class 2 only because she had said that she got short of breath with some kind of mild activity. That's arguable, but that's where, in my note, that's what I said. She's a CarPreg score 3 because of her prior arrhythmia. She had a relatively normal CPET. So what do we tell her? We gave her about a 15% risk of cardiac complications during pregnancy. That's by CarPreg. By WHO, that is kind of 5 to 10%. Given her TET, she maybe has the potential for a faster RV deterioration compared to if she didn't get pregnant. We advised close cardiology and MFM follow-up. We wanted her to have a vaginal delivery. She ended up not having a vaginal delivery, but that's what we wanted to try. Thinking about the AP Fontan, and this is, I bring this up because this also tells you that these scores aren't perfect, because, so she is World Health Organization class 3. She was New York Heart Association class 1. Quote, totally asymptomatic. She's also a CarPreg score 3 because of her prior arrhythmia, because there's nothing in here about a Fontan. Interesting. She's on, the thing that this does add is that, you know, other medication, anticoagulation, she was on therapeutic anticoagulation, which does increase our kind of risk profile for her and makes us think about her. By CarPreg, she would also have a 15% risk of cardiac complications. By World Health Organization, that risk is up to 30%. This is why I find it helpful to kind of look at two different scoring systems, because it gives you a sense of the range of complications that these women might have. We told her that she had an unclear long-term impact. She needed close follow-up, and again, for her, we would have preferred for her to have a vaginal delivery. She didn't have a vaginal delivery, not necessarily because of her Fontan, because we were very worried about it. So hopefully I've done a little bit of this. Maybe I've made you worse, I don't know. 2% of pregnancies involve maternal cardiovascular disease, with congenital heart disease being the most common in reproductive age women. It's important to think about this because, as I showed you, maternal mortality is increasing in the US, and cardiovascular disease is the most common cause. I hope I've convinced you that informed cardiovascular evaluation is ideal to do pre-pregnancy with some counseling. And then I'll leave you with just make sure you think about maternal hemodynamics, because they really change in pregnancy. And it's really kind of fun and fascinating to think about and watch it happen. This is the whole team. Requires a village to take care of these women, and I thank all of you for helping me take care of them. And I will take questions.